Hi, I'm Glenn Sasek, introducing Dr. Toub. From New York State, Dr. Toub moved westward to join Providence Brain and Spine Institute team in 2010. Prior to beginning her medical career, she completed her undergraduate work in anthropology and biology at Brandeis University and attended medical school at Albany Medical College. She then went on to complete her medical internship, neurology residency, and epilepsy fellowship at the Cleveland Clinic in Cleveland, Ohio. Dr. Toub currently serves as the medical director of neurodiagnostics for the Providence-Portland region, where she is excited to be part of a highly motivated, growing team of epilepsy providers. She is enthusiastic about the opportunity to work closely with patients and their families in tackling the challenges imposed by living with epilepsy. During her free time, she enjoys hobbies including photography, hiking, knitting, traveling, and spending time with family and friends.
And whether you can see me or not, I assure you that there is a speaker standing behind the podium. Some of you out there, this may or may not apply to you. I am really happy to be talking about this topic. This is a topic that is actually probably one of the most exciting areas in epilepsy. A significant number of the patients that we tend to see in our epilepsy clinics really have this problem, and it's a problem that really affects not only the patients, but their families as well. So just a little bit of background. I apologize if there's a little bit of redundancy with some of the topics that have already been discussed. My figures may differ a little bit. We all gather our figures from different papers. But for the most part, epilepsy is a very common condition. It affects about 50 to 60 million people worldwide. About 2.5 to 3 million Americans are affected by the disease. And most people really think that this is an underestimate because of the reasons that Dr. Evans discussed, particularly the fact that many seizures are subtle. They can be unrecognized, and oftentimes the diagnosis isn't very clear-cut. Sometimes people may not be diagnosed with epilepsy when in fact they have the condition. And then if we think outside of cultures other than the one that we're familiar with in the US, in some cultures there's a significant stigma attached to any sort of neurological or psychological illness. And so some patients may never seek out care for their condition. The reality is that if you're in a room with 100 people in it, 10 of those people will probably have had a seizure at one point in their lives. Approximately 10% of the population is affected by this disease. And the good news is that about 1 to 3% will have a diagnosis of epilepsy. The good news is that 2/3 of these patients will actually have very good seizure control with medications alone. So the medications that we have, as Dr. Dempster has presented, we've gone leaps and bounds over the last 2 decades with medication development, and we have a plethora of seizure medications to choose from. And our armament is really successful in controlling the vast majority of patients that suffer with the disease. On the flip side, about 1/3 of patients with epilepsy are not well managed with medications. The International League Against Epilepsy, again, this big kind of international group of epilepsy specialists that kind of come up with rules and definitions, they diagnose intractable epilepsy or medically refractory epilepsy as when a patient has failed to become and stay seizure-free with at least trials of 2 separate medications. It's important that the medications that are selected are not only appropriate for the seizure subtype that the patient has, but they also need to be used at adequate doses to control seizures. So for instance, a person that may be started, let's say, on a medication like oxcarbazepine or Trileptal is the brand name for that drug, they may have a rash after the drug is started at a very low dose. So even though they've really not been able to tolerate that medication, whether you can truly deem it a medication failure is a little bit questionable because the medicine never actually reached a blood level that was sufficient to control their seizures. So the first step before deeming somebody as actually refractory is to try to come up with some ideas as to why that person is not having their seizures well controlled. The first thing is, well, did we make the right diagnosis? As Dr. Evans alluded to, not everything that shakes is actually an epileptic seizure. So one thing that we really need to consider is, well, we're treating this person appropriately for seizures. Well, are we treating the right condition? If you don't give somebody medication to treat the appropriate condition, then obviously the condition isn't going to be resolved. Are the prescribed medications appropriate? Not all seizure medications are appropriate for all types of epilepsy. In fact, there are some medications, particularly some of the medications that are indicated for treatment of generalized epilepsies, that may in fact exacerbate some of the seizure subtypes for people with focal epilepsies. Are people taking their medications appropriately? Unfortunately, a lot of the medications that we have really need to be taken according to a strict dosing schedule. As you can imagine, when you take the medication, shortly after the medication is taken, within a few hours, the drug reaches a peak dose, and over the course of the day, that medication level can drop. Different people require different therapeutic doses depending on what their personal threshold is. And so if that medication level drops below that threshold, there's a potential for a seizure breakthrough. This day and age, we're starting to develop more extended release formulations. So that wearing off effect can sometimes be thwarted. Are there other factors that can be contributing? While seizures are a reality for our patients, a lot of them also have many other comorbid illnesses, whether it be mental illness or physical illnesses. They may be on other medications that can be interacting with their seizure medications and dropping the level. Stressors can definitely make it easier for people to have seizures. It's easy to say, get a lot of sleep, make sure you have 7 to 8 hours of sleep a night, try to avoid alcohol, but the reality is that life carries stress with it, and there isn't a pill that takes away the stress of giving a talk to a room full of people for the International League against for the Epilepsy Conference. And there are things that people may or may not perceive as stress that they may not even be able to recognize as a stress unless we actually talk to our patients in the office and try to figure out what those stressors may be. Some women, for instance, may have a higher instance of seizures around their menstrual periods. And it's important for us to talk to patients because if people give us that sort of information, we can give some recommendations on how to maybe alleviate those. So after we kind of clarify the fact that patients are indeed medically refractory, they're on adequate medications, their levels are good, they're taking their medications as directed, what are their options? We generally say that after they've tried 2 medications, we should start at least entertaining the possibility of doing something in addition to medication therapy. The biggest thing that we like to try to offer patients, mainly because in some patients it can potentially be curative, is the option of epilepsy surgery. While we'd like to think that that's an option for everybody, really there's a small number of people that would be adequate candidates for surgical resection, and I'll go into that in a little bit more detail as we go on. Neuromodulation is just kind of a fancy word for these new innovative devices that are available now on the market that can be implanted through minimally invasive surgery to try to modulate seizures, reduce seizure frequency. Neuroablation is kind of a little bit newer in the literature. There are some laser technologies which can be used to get rid of some of the seizure foci that can sometimes be identified in imaging. And then lastly, there are some dietary modifications that we can offer patients, which are often very effective in reducing seizure frequencies. So surgery, I think, is probably the hottest topic and an area of interest for a lot of people. Which patients can we offer these to? So as alluded to, really, epilepsy surgery is not a viable option for a lot of patients. Patients with generalized epilepsy really are not going to be adequate candidates for epilepsy surgery. When we think of taking out part of the brain, we're trying to take out the part of the brain where the seizures are generated. You can imagine somebody with generalized seizure has an electrical storm that's generated all at one time throughout the brain. And for obvious reasons, we can't take out somebody's entire brain. So the generalized epilepsies, we'll have to hold off on them, and we can talk about some other options that may be available to them other than surgery. Favorable surgical candidates. Obviously, like we alluded to, focal epilepsy patients. All seizures, we want them to quote-unquote look similar. And what that means is that if patients have multiple different seizure subtypes, there's a possibility that their seizures are coming from different areas in the brain. And so we can't go in there chopping out little pieces of brain all over the place. The brain is a very highly structured organ, and it has a lot of vital functions. And so our goal is to be able to reduce seizures or eliminate seizures without the expense of causing them significant deficits like problems with speech and motor function. Do they have an underlying lesion? So we know that patients that are what we would label as lesional epilepsy. So if we did a brain scan and we look and we see that there's a small tumor or a way that the brain formed abnormally during development, those sorts of patients would be more amenable to resection simply because we can see the area that's causing the problem. We don't want them to have involvement of eloquent areas. So you may see this terminology, eloquent. Again, those are areas that serve vital functions like speech function or motor function. We're usually a little bit willing to accept some mild visual field deficits at the expense of alleviating high seizure burdens. And even some small sensory deficits would be reasonable, but obviously every case is different, and we need to have these discussions with patients to see what's an acceptable outcome for each individual patient. And then finally, when we do these evaluations, there's a whole slew of tests that are involved. And ultimately, our goal, our favorable candidate is going to have every single test identifying a single seizure focus, a single point in the brain that's responsible for the seizures. If the data isn't concordant, so if the MRI tells us one thing and the PET scan tells us something else, then we have to scratch our heads a little bit and then maybe brainstorm about whether or not there are other options other than surgery. The Epilepsy Monitoring Unit, I think, is probably one of our favorite friends in the epilepsy world. It's a very useful tool. I think that it can be a little bit overwhelming for patients. Generally, probably a lot of people here or family members have gone into the Epilepsy Monitoring Unit. What it entails is bringing patients into the hospital for a series of days. We monitor them continuously on EEG, and we also keep people on video and cardiac monitoring throughout the study. And we may reduce or stop medications. And when we do that, our goal is to actually try to capture the seizures that patients are having. And ideally, we really aim to try to capture all of the different types of seizures that people are having for a couple of reasons. Number one, we want to try to localize where the seizures are coming from. Are all of the seizures that patients having coming from one particular area, or do they have seizures that are coming from all over the place? We want to see what they do during their seizures. The really cool thing about neurology is that you can oftentimes tell where seizures come from on the basis of what people do during their seizures. So as Dr. Evans alluded to, if their right arm starts twitching, then the motor area on the left side of their brain is causing their seizures. If they all of a sudden start talking gibberish, there's an area in the temporal lobe that is responsible for the sensory component of speech, and that may give us a clue as to whether that may be the area where their seizure is arising from. Sometimes there's this interesting effect where we bring people into the monitoring unit, we have them put their feet up for 3 days, or meals are brought to them. They're removed from the stress of life, and so even though they may report that they're having seizures very frequently, they may have nothing when they come into the monitoring unit. And in those situations, we try to do things to try to induce their seizures. We may sleep deprive them. We have a couple patients that may say that alcohol reduces their seizure threshold and makes them have seizures, so we've been known to order alcohol with their meals. We may flash lights in their eyes, make them hyperventilate, and some patients notice that they have exercise or any sort of exertion induces their seizures, and so we may have them pedal a bike bedside. Obviously, we can't have them running marathons because of safety reasons, but we do what we can to try to reproduce the seizures that they're experiencing at home. For patients that I see in clinic that give me any sort of a history that is coincident with a possible focal seizure disorder. So they might say, I have a funny, weird feeling in my stomach, and then I get this really prominent deja vu. To me, that sounds like a possible temporal lobe patient. Anybody that has any sort of focality whatsoever on the basis of their history should have some sort of brain imaging, ideally an MRI. Patients with pacemakers are not able to have MRIs. Patients with a vagal nerve stimulator, which is a device I'll talk about a little bit later, they are able to have MRI scans. The device does need to be turned off, and there are some certain protocols and approvals that need to be made through radiology in order to make that happen. The reason for the MRI is simply we're looking for a focus. We're looking for where the seizure is coming from. Is there a tumor? Does the patient have some sort of an abnormality in their blood vessels, like an aneurysm or malformation in the way the blood vessels communicate? Is there an abnormality in the way the brain developed? Has the person had prior head trauma, and as such there's some scarring on the brain? Has the person had a stroke? A lot of patients come to me at their first visit and they say, well, why am I having a seizure? And unfortunately, while we would love to be able to answer that question, as Dr. Evans showed you, a very large percentage of these patients we really can't give answers to. It's sometimes satisfying to be able to say, here's why you're having your seizures, here's your MRI scan. But our ability to find foci is only as good as our technology. And so what we do know is that even though patients may have what we would call a non-lesional MRI, we send them to MRI, there's nothing abnormal on the MRI. If these patients do go on to undergo surgery, sometimes when we look at that tissue under a microscope, it's not normal. And so even though patients are quote-unquote non-lesional, we're only as good as our technology. This is just an example, a couple examples of some of the things that we look for on MRI scan. On the far left, that's probably quote-unquote no-brainer. No pun intended. It's a pretty easily identified lesion. It happens to be over the patient's right kind of parietal area, frontoparietal area. And low-grade tumors can oftentimes be there for many, many, many years before they grow enough to actually cause any symptoms. The two images in the middle are actually from the same patient. They're slightly different sequences. Cortical dysplasia is a fancy word for an abnormality in the way the brain developed. Cortical dysplasias are notoriously refractory to seizure medications. That's not to say that everybody with dysplasia won't respond to medications, but we do find that a significant number of patients that do have medically refractory epilepsy do have abnormalities in the way the brain formed. That outer ribbon of tissue, this kind of stuff that looks dark, is the cortex. The cortex is the part of the brain that is responsible for generating seizures. And in your average normal human being, it's very exquisitely organized into a set of layers. Sometimes when the brain forms, the neurons, they're supposed to migrate from the middle and kind of set up in those neat layers, but sometimes they can get stuck along the way, or the layers can get jumbled, and when that happens, they get angry and they produce electrical storms that produce seizures when we see people in clinic. This last one is a little bit subtle. I'm not sure. Yeah, I think you probably can see that there is a little bit of symmetry. One of the cool things about the human body is we have pretty much two of almost everything, and nature likes symmetry. So we like to see if things are symmetrical. And whenever there's any sort of asymmetry, it makes us scratch our heads. And so here, I don't know if you can appreciate, but in this middle part, this is the temporal lobe. This area over here is the temporal lobe. And in the middle part, there's this subtle brightness, and maybe the tissue is a little bit smaller. This is scarring down of the middle part of the temporal lobe. Mesial temporal sclerosis is the fancy name we give it, or hippocampal sclerosis. People with that sort of abnormality are also, unfortunately, often refractory. So besides our conventional EEG on our monitoring units, there are a lot of different steps to a pre-surgical evaluation. It's not simply, oh, your EEG shows you have seizures coming from there and you've got a lesion, let's just chop it out. There are a lot of steps that we take to take precautions and make sure that we're really taking out the right part of the brain. One of the first steps is neuropsychological testing. Neuropsychological testing is interesting. It's important because it helps us to delineate not only whether or not somebody has a problem with memory, which is a very, very common problem with patients with epilepsy, but it helps to determine a pattern of memory loss. And deficiencies in certain areas may give hints as to where the seizures are coming from. It's sometimes a little bit difficult to interpret the results because, as you probably are aware, seizures are likely to produce some problems with memory. And then medications inhibit your brain's normal activity. And we don't have medications that target the neurons that are just misbehaving. They do have some effect across the board. And so sometimes medications can also cause some memory dysfunction. The neuropsychological evaluation is also important in kind of outlining if there's any other psychiatric problems that may be going along with the seizures. Those are important to recognize because they may be playing a role in the person's quality of life, and they may not resolve with treatment of the epilepsy or resection of the lesion. This is just a slide similar to one that actually Dr. Evans showed you. Neuropsychological testing, if anybody has ever played Lumosity or those kind of brain games online, it's kind of the same idea. So they're basically a series of tests that are designed to hone in on a particular area of brain function. There are some tests that test executive function, so ability to problem solve and plan and carry tasks through. That generally is a frontal lobe function. In addition to those things, attention, personality, emotion, motor. There was one lady earlier that mentioned that her child had bouts of rage and outbursts, and those would be areas that would be something related to frontal lobe function. Patients with problems involving the back of the brain, the occipital lobe, that's where the visual centers are, so they may have some problems with visual processing. The temporal lobe is kind of sneaky because it's really intricately involved in pathways that connect to a lot of different areas of the brain. People with problems that affect kind of the lateral part of the temporal lobe, so not the middle part that I showed you that's scarred down, but the more lateral part, that's where hearing function is. So people with lateral temporal problems may have issues with hearing, processing hearing cues, verbal memory, so there's some aspect of verbal function that is held within the temporal lobe. And then although the primary visual areas in the back of the brain, the way the vision pathways go throughout the brain, the light comes into the brain and then the visual pathways actually traverse over the temporal and parietal regions. And so there may be some problems with visual perception in patients with temporal lobe abnormalities. And then the parietal lobe is particularly involved in visual spatial processing. So Dr. Evans alluded to a patient who, when they had seizures coming from their parietal lobe, they felt like their couch was being flipped over upside down. That's typical for parietal lobe pathology. And so there are tests really that are designed to test each of these different domains and hone in on any particular areas of weakness. Just of note, neuropsychological testing is a tool that's not really just reserved for patients who are refractory. We actually use it across the board. Memory is probably one of the biggest complaints that patients have in clinic. It's important to identify where their weaknesses are and really establish some sort of a baseline, because memory is really a very subjective thing. And once people start to notice that they have a deficit, they may kind of become a little bit obsessed with it and focus in on it, and they may start to perceive that their memory is declining when in fact it's not. So oftentimes when I have patients that come in with memory issues, I may send them for a baseline neuropsychological evaluation so that 5 years down the road, when that person comes back and says, you know, doctor, my memory is just getting so bad, I can send them back and see if in fact their memory really is declining or if it's just something that the patient is noticing more. So now to some of the kind of cooler techniques that we have and the kind of different types of neuroimaging. And again, Dr. Evans already honed in on some of this. PET scans are really neat scans. They're used to look at differences in brain metabolism throughout the brain. And again, this is an area where symmetry becomes really important. When a patient goes in for a PET scan, they have an IV that's put in place and a radio tracer that has glucose attached to it, which is primarily the source of energy for the brain, is injected into the patient. And what we look for is differences in brain metabolism. You may find that most centers, I know ours does, and I think OHSU does as well, when we send patients for PET scans, we actually have patients have EEG done while they're having the scan, because whether or not the person has a seizure during the study, or even if there's a really high amount of irritability, that may actually affect the result of the scan. So what we find is that patients between seizures, so when they're not having seizures, if they have a part of the brain that isn't functioning appropriately, that part of the brain doesn't take up that tracer to the same degree as the rest of the brain. And so what you'll see is this is a patient with right temporal lobe epilepsy. And as you can see, I think this is pretty obvious that there's a difference in this right temporal lobe compared to the left temporal lobe. This is a normal patient. If this person happened to be having a seizure, you might actually find the opposite. So you may actually find that this is very bright, because if you can imagine, a seizure requires a huge amount of energy. So it's just going to suck up all of that contrast and it's going to glow brightly on the PET scan. So the PET scan we often do in conjunction with an EEG so that we can determine whether or not somebody's having a seizure during the study. SPECT scan. The SPECT scan is actually also pretty interesting technology. It is available at some centers. Again, it's used really as a last resort when we don't have information that we need from all of the other testing that we've had done. It's a pretty labor-intensive test, and it relies heavily on luck and whether or not we're lucky enough to have a seizure at the right time. Where I trained, they used to have a nurse that would sit bedside basically in the EMU all day. And basically the way this study works is that we send somebody for a baseline SPECT scan. So they're not having a seizure. We want to see what happens with blood flow and oxygen uptake basically when somebody isn't having a seizure. And then the next day, a nurse will sit bedside and wait for that person to have the earliest sign of seizure. And as soon as that person starts having a seizure, they inject this radio contrast. And it's highly important that that contrast is introduced right at the onset of the seizure. Otherwise, we may not actually be seeing a seizure focus, but the way that the seizure propagates. And then after the person has that injection done, we bring them back for a repeat SPECT scan. They take those two studies and they subtract them. And then the area where the seizure is happening shows up brightly, because when they have a seizure, it's taking up all that extra oxygen and blood flow. And that can be superimposed on top of an MRI scan. So it's very useful, but it's also very operator dependent, and it really needs to be done correctly to be a useful study. Magnetoencephalography. This is one of those tests that really is used when we've done PET scans, we've done MRI scans, we've done EEGs, we've done the epilepsy monitoring unit, and we're just not getting the information that we need. Sometimes EEGs are not always that sensitive in detecting seizures or even abnormalities between seizures. A lot of that has to do with where the seizures are coming from, and the way the abnormal electrical activity is propagated. Most people that have abnormalities, the abnormal electric activity is oriented kind of perpendicular to the surface of the brain. And that's what EEG is really good on picking up on. But sometimes, especially some patients with dysplasias, for instance, when the architecture of the brain isn't normal, that electrical activity isn't oriented in a way that's easily picked up by EEG. And so we might actually miss it on an EEG scan. And so the MEG, the magnetoencephalogram, is designed to actually detect changes in magnetic field that's generated by a flow of electricity. I'm not going to go into the physics of it. That's not very important. But it can be an extremely useful case, particularly in patients that have EEGs that really haven't been very helpful in localization, and also in patients that are MRI negative that don't really have obvious culpable lesions. The neat thing is that the data that's obtained from the MEG can actually then be superimposed on the MRI scan for precise localization. The caveat is that it's extremely expensive technology. It's not available widely, so patients will often have to travel quite far to have it done. And so it really is reserved for patients that have medically refractory epilepsy, have focal epilepsy, and we just are not able to figure out a good surgical strategy on the basis of all of the other technologies that are available. All right, so we've decided that this person is possibly, a good surgical candidate, but we really want to make sure that we're not going to leave patients with deficits that are going to be an unacceptable quality of life. So the big things that we really want to map are motor function. We want to figure out, if we take this part of their brain out, are they going to not be able to move their right arm? And we also want to figure out where their language is, because while most of us think of language as ability to speak, it's a lot more than that. It's ability to understand. And so it's just not, taking out somebody's language area could potentially just not make it so that they're not able to speak, but they may not be able to communicate or understand anything anymore. And so that, I think for most neurologists, is really an unacceptable outcome. So we really don't want to leave our patients with that deficit. So there are really two different modalities that we use. The first one is functional MRI. Again, Dr. Evans did speak a little bit about functional MRI. What it does is it basically detects changes in blood flow while patients are performing tasks. Dr. Evans talked about, moving your finger, and then you see the finger area light up on that part of the brain. And similar, there are language paradigms and speech paradigms that can be given to the patient while they're in the MRI scanner, and we see what areas of the brain can light up. While that's great and it's suitable for most cases, there are some cases where we want data that's even a little cleaner and more conclusive. And so there's a test called a WADA test named after the guy who started doing it. They use a numbing agent, amytal, basically, and they introduce a catheter into the brain, actually into the carotid arteries. And if you can think about what would happen if you numbed half of your brain, and that's basically what we do. So we introduce the catheter into one carotid artery, they inject the numbing agent, and that effectively puts that side of the brain to sleep. We confirm that side of the brain is asleep because the person won't be able to move the opposite side of the body. And then this is predominantly for localizing speech function and memory function. And so if we inject one side of the brain and the person isn't able to speak and their memory is affected, we can tell that that part of the brain is the side of the brain where their language function is. Most people here are probably right-handed. Most people will have their language function in their left hemisphere. Even left-handed patients, a lot of them will have left brain dominance. But what we find is that there are some people that have language function on both sides of the brain. So these tests are really important in kind of outlining the areas of the brain that have what we would call eloquent function, and ensuring that we aren't going to take those parts out by doing epilepsy surgery. All right, so we've done our whole evaluation. We've decided, this person may be a great candidate for epilepsy surgery. There's not a lesion. We don't know what we can cut out, but we know that it's coming from somewhere around, the right temporal area. What can we do? And so there are kind of some more invasive techniques for mapping seizures that we use. The vast majority of patients will use, the vast majority of centers use a technique using subdural grid electrodes, and I'll show some pictures of what those look like. It's basically a flat sheet with a bunch of little electrodes on top of it, and those can be placed through surgery. The patient is brought into the operating room, part of the skull is removed, and the grid is actually placed right on top of the brain surface. And then the person is brought back, and a similar evaluation similar to the epilepsy monitoring unit is done, but generally it's usually a little bit longer. And the idea is to really pinpoint where that focus is. We want to give people good outcomes, but we want to take as little bit of tissue out as is necessary in order to preserve brain function. Kind of like the idea of giving people the lowest amount of drug that they need to control their seizures. We really want to minimize any sort of damage to the patients as possible. The benefit to this sort of technology is it allows for us to map brain function. So for instance, if we're in an area that's getting really close to that person's speech function, once that grid is placed, we can actually stimulate individual electrodes on that grid and see what happens to patients when they have that stimulation done. So if you stimulate an area and their arm jumps, that's where their arm function is. If you stimulate the area and they can't talk, you're right over their speech area. And so we don't want to take those areas out. So it's actually a very useful tool, not only for diagnostic purposes, but also for mapping out vital functions of the brain. In addition, we can use they look like shish kebab skewers, kind of. They're long depth electrodes. And instead of a flat sheet of electrodes, it's like a long skewer with anywhere between 4 and 8 electrode contacts on them. And they're simply placed through burr holes. We may use them in conjunction for grid electrodes. And they're really useful in picking up abnormalities in deeper areas of the brain. It's not unusual, for instance, if we have a pretty good idea that somebody has seizures coming from their left temporal lobe, but on their EEG, we might see a little bit of irritability on the right side. Sometimes discharges can localize falsely on scalp EEG. So it wouldn't be unusual for us to put a grid electrode over the left side and then put depth electrodes on both sides to try to just make sure that this person doesn't in fact have seizures coming from both temporal lobes. As we discussed, we then bring them into the monitoring unit. They'll stay. Usually it's, 1 to 2 weeks is a kind of reasonable amount of time. If we get really lucky, the person is in there for 3 days and they've had like 18 seizures and they're all coming from the same place. We don't need to keep them there for 14 days. We can obviously do the surgery sooner. There are some limitations to this type of evaluation. So the subdural grids, as you can imagine, your head is actually, it's a fixed cavity. It has a fixed size. You can only fit so much stuff in there. So if you've got somebody that has really poorly localized seizures that you don't know exactly where they're coming from, you just can't cover the entire head with grid electrodes. You have to have some idea because you can only pack so much in there before you start to compromise patient safety. You don't want people's brains to start pushing down and compromising their breathing and whatnot. So we really do have to have some sort of hypothesis before we can go ahead and do this grid electrode. And obviously, whenever you cut open something and there's exposed tissue, there's risks for infections, bleeding, and then swelling. And again, this is a fixed cavity, so there's only so much that the brain can swell. So again, we can't just cover the entire head with electrodes. This is just a picture to kind of give you an idea of what it is that they look like. The top right, those are kind of what the grid electrodes would look like. They come in different sizes. And the sizes that are used really depend on how much coverage that you want. And on the bottom is an example of what a depth electrode might look like. And I don't know if you can see, it's kind of subtle, but these little areas here are kind of the little electrode points. And then again, these are little tiny electrodes. So if you remember back to when you all had your EEGs as an outpatient, it's not that many, it's like 20 channels. So this little tiny grid is actually quite small. So you can imagine how much more detail that you're getting. And we're right directly on the surface of the brain. So we're able to detect things that may not necessarily be picked up on scalp EEG. And so here's a kind of a schematic and then actually a real life picture. I tried to pick something that wasn't too bloody. I didn't know if there are some people here that were not keen on blood, but this is a kind of a picture of kind of a way that we might use these. So this is kind of one large grid of electrodes and then two smaller ones. This patient here, this is the same one after, this is what it looks like on an x-ray. And then you can see that this person actually also has some depth electrodes that were placed in addition. And this is actually an intraoperative picture of what it looks like directly on the surface of the brain. This is just a slide again, kind of stressing the idea of functional mapping, that we can really find out where areas of function are by stimulating these electrodes. And it can be really helpful in determining whether or not this is a procedure that we can safely go through. So a less common type of invasive evaluation that is used in some larger epilepsy centers, and it's actually used, I think, more commonly in Europe. It's called stereotactic EEG. And if you remember those depth electrodes that I talked about before, it's a similar concept, but instead of using these grids, the depth electrodes are just kind of placed all over the place. And you'd think, well, why would you want to do that if you can just focus in? But as you may recall, there are some patients where we know their seizures are focal because, you know, of what they do during their seizures, and we think that they're all coming from one place because they all look the same. But the EEG and the MRI hasn't really given us much of a clue as to where they're coming from. And so the benefit of stereotactic EEG is it really allows for much more widespread coverage, because you don't have to worry about that, what we would call mass effect, you know, the filling this fixed cavity with tons of giant grids. You can cover a pretty large area and get a better idea of where seizures are coming from for patients that really you wouldn't otherwise be able to devise a good grid strategy. The pros, really, it's less invasive. The cons or limitations, you can't really do any functional mapping. So if you are trying to figure out where somebody's speech area is, this wouldn't be the technology that you would want to use. It is offered at few epilepsy centers. It's becoming more common. I think when I trained, it was used in only a few centers across the U.S., and I think as there's more data, more and more centers are becoming comfortable with it. So this is just an example. This is a patient who has a right temporal focus, not really sure where it is. You can see a whole bunch of depth electrodes that have been placed. Similarly, this is a patient that had focal epilepsy on the basis of what they did, seizure semiology, what they do during their seizures. But the MRI data wasn't really able to give us a good idea of where that grid should be placed. And so you can see that they have depth electrodes kind of placed all over the place with the hope that one of those is going to pick up on the seizure focus. A lot of patients ask, well, if I go in and I have this, if I can have surgery, when will the seizure focus be taken out? With patients with subdural grids, the vast majority, and obviously there are outliers depending on every individual case, but most patients with subdural grids, if the grid evaluation really is able to localize a focus, and that focus doesn't involve areas that we wouldn't want to take out, then usually the resection would happen at the time that the grids are removed. Most patients that undergo stereotactic EEG, usually there's several weeks in between when the stereotactic EEG is done and when the surgery is actually done for a resection. And I think the most important thing for people to understand is that this is our effort to try to find a focus that is amenable to surgery, but unfortunately, not all of these evaluations end up in surgery. So if we do an evaluation and somebody winds up having 3 different foci, or if their motor area or their speech areas are involved, unfortunately we can't offer surgery to every patient that undergoes one of these surgical evaluations. Other expectations. most of these patients that we send are people that are really incapacitated by their epilepsy. And so not all patients that have epilepsy surgery may necessarily be completely seizure-free. It depends on every individual case what sort of outcome people are willing to accept. So if they can, do with a seizure reduction by, 70%, that may be acceptable. It may significantly improve somebody's quality of life. Sometimes we can't take out the entire focus. So there may be a widespread focus, and part of that is over the area of speech. So we may take out as much as we can without affecting speech function, and the outcome may be that they may continue to have seizures, but hopefully at a reduced rate. And then for a significant portion of patients, they have non-epileptic seizures. And so, again, this is a treatment for patients with epileptic seizures. So if somebody also has comorbid seizures that are from mental illness or stress, psychological illness, it's not likely that these epilepsy surgeries are going to reduce the frequency of those. And then a lot of patients think that this surgery may make it possible for them to completely stop medications. And the reality is that the vast majority of patients will continue to be on medications, hopefully just one. There are a significant number of patients that at some point may be able to come off medications, but at least for several years postoperatively, the expectation should be continuation of some anti-epileptic therapy. How do these patients do? Temporal lobe epilepsy patients tend to do the best. The good news is that temporal lobe epilepsy is probably the most common type of focal epilepsy, so a lot of our temporal lobe patients that are refractory may have better outcomes. These numbers are pretty broad. You want us to pin down numbers for you, but depending on what study you look at, seizure freedom rates range anywhere from 50 to 90%. Those that do the best are patients, obviously, that have epilepsy in one place, in one temporal lobe. They have a lesion that you can identify in MRI, and all of their EEG data is concordant, meaning when we do our EEG evaluation, all of the abnormality is coming from one place. We don't see some irritability coming from other parts of the brain. Unfortunately, patients that have seizures coming from areas outside the temporal lobes don't fare quite as well. The numbers range anywhere from 30 to 50% for seizure freedom. And the best outcomes, again, are those with lesional epilepsy and no involvement of areas of the brain that are eloquent. So what about the patients that aren't good surgical candidates, and perhaps the patients that have generalized epilepsy that are intractable? There are some other options that we can offer. For some patients, even that may be good surgical candidates, they simply are just not comfortable with proceeding with surgery. And so neuromodulation is kind of an exciting area that is evolving. The most common, and I'm sure most of you have probably heard of vagal nerve stimulation. There's a newer technology called RNS, or responsive neurostimulation. And then there are some techniques that are still experimental in the United States, which I'll kind of allude to a little bit later. So vagal nerve stimulation, what is this? First and foremost, it's approved for treatment of medically refractory generalized and focal epilepsies. It's a device that's about the size of a pacemaker, and in most patients, we implant it on the left side of the chest. For patients that have a pacemaker, it can be placed on the right side of the chest. And it's a small generator that's connected to a lead, and then the lead has a small area of electrodes that basically envelops the vagus nerve. The vagus nerve is an interesting nerve. It kind of wanders a lot, and it kind of has a lot of kind of brain contacts. And nobody really knows exactly why the device works. The physiology isn't entirely certain, but a lot of patients don't really care, and a lot of physicians don't really care. If it's doing what it needs to do, then great. The mechanism, like I said, is poorly understood. This is a kind of a picture of what they look like. The efficacy is about as similar to use of another medication. So when patients say, well, doc, is this going to make my seizures go away? We say, well, we've tried a lot of medicines. You haven't tolerated them. They're causing side effects. The nice thing is that it's a device that isn't going to have the sedating effects, the cognitive effects that polypharmacy has with using multiple seizure medications. Side effects, the device, basically the way it works is it's implanted, and there are program settings that we can do in the office where the device automatically turns on and off every 3 to 5 minutes. And when we can control the strength of the stimulation, we can control the amount of time that the stimulation is on. The side effects generally coincide with when the device is turned on. It is going and cycling all the time. So it's not going to just fire when the person's having a seizure. It's always actively cycling on and off every 3 to 5 minutes. When the device turns on, because of the proximity of the vagus nerve to the laryngeal nerve and the throat area, patients oftentimes can get a little bit of a raspy sensation, and their voice may change temporarily while the device is on. They may start coughing. They may note a tickling at the back of the throat, and I apologize for some of these typos. The good news is that a lot of those tend to get better with time, and the adverse effects tend to be more tolerated as the person becomes used to the device. The settings are gradually increased about once every 1 to 2 weeks in the office, and everybody needs different settings. The nice thing about this device is that patients can get a sense that they have some control over their seizures. So some people that have an aura or family members can recognize early signs. There's a magnet, a very strong magnet, which can be swiped over the device. And what that effectively does is it increases the impulse temporarily that is delivered. And sometimes that can actually interrupt the brain waves and prevent synchronization in the brain and hopefully prevent a seizure. And so the device has been shown to be effective in reducing seizure frequency. It's a pretty simple day surgery procedure. The whole procedure takes between 45 minutes and 2 hours for implantation. And depending on the settings and how frequently the patient is swiping, the battery life is up to 10 years. And battery swaps are a very quick, minimally invasive surgical procedure, taking probably less than an hour. Again, there are MRI limitations, so if you do have one, you should let your doctor know before they order any MRI scans. RNS is a newer technology. Theoretically, it sounds like a great idea. It's different than than VNS in that it's a device that isn't always on. It's indicated for patients with focal epilepsy and is particularly recommended for patients, for instance, that aren't good surgical candidates because they have 2 foci. And so there can be up to 2 foci. The generator is implanted flush with the skull. There's a piece of skull that is removed. The generator is put into place. There's no bump, so you can't, tell that somebody has something sticking out of the side of their head. And then there are electrodes that are basically targeted at the areas where the seizures are coming from. Obviously, you need to know where the seizures are coming from for it to work. They're almost like little miniature EEG detection devices. And when the electrode starts to sense that there's some synchronization and abnormal activity in the area, it can deliver a jolt, and that can prevent the seizure from propagating. Sounds like a great idea. In practice, it's probably about as effective as a vagal nerve stimulator. But to date, there really have not been any head-to-head trials between VNS and RNS, so it's a little bit hard to draw any definite conclusions. So some other things on the horizon. I'm going to be quick because I'm getting to the end of my time. These are a couple techniques that are available in Europe. They're not approved in the United States, and the efficacy is a little bit kind of not yet certain. Deep brain stimulation is actually a technology that's approved for treatment of Parkinson's disease in the United States. Again, the mechanism isn't very well understood, but it does result in some degree of seizure reduction. This external trigeminal nerve stimulation is also an interesting technology. Unlike the others, it doesn't really involve any sort of surgery at all whatsoever. It's basically this kind of gel material that's placed on the forehead for 10 to 12 hours a day. I think most patients probably use it while they're asleep. And it delivers some sort of impulse to the trigeminal nerve. Again, nobody knows exactly why it works, but it has been shown to produce some sort of seizure reduction. And then I'm going to kind of breeze through neuroablation, or visual ACE is the most common thing that it's called. It's basically a laser technology that can be used to hone in on a specific focus in the brain or more than one focus. Perhaps it's an area that isn't easily reached through surgery or isn't an area that's really amenable to a large resection. It's a laser that is delivered through a cooling sheath. And so that laser basically can burn out the abnormality, but the cooling sheath prevents damage to areas around the area that's targeted by the laser. It's a relatively new technology, not available in many centers. I think we'll start to see it more over the next several years as we gather more data. And then finally, I did want to touch base a little bit on epilepsy diets. I know that sometimes it's hard to find a diet program. Diets habitually have really been used for pediatric epilepsies. The most famous one would be the ketogenic diet. This is notorious for being a very high-fat, low-carbohydrate diet. And by low carbohydrate, it may be even things that you may not even think about, like carbohydrates contained in toothpaste and cough syrup. It's 3 to 4 grams of fat per 1 gram of carbohydrate, which it's the equivalent to about 90% of calories from fat. In you and me, we get most of our energy, our primary source of energy is actually from glucose, which is a carbohydrate. What this diet effectively does is it switches over that primary source to fat. And the byproduct of that fat metabolism is ketones. It's has been shown to be highly effective in some patients with epilepsy, particularly in some of the catastrophic pediatric epilepsies. It's generally, if it's shown to be effective over a few months, it's usually continued for about 2 years and then stopped. Again, this is one of those head scratchers. There are a lot of ideas of why it might work. I'm not sure that anybody knows exactly why it works. It's a pretty difficult diet to adhere to. The foods that are on here are pretty much the sorts of foods that people have to eat. So most adults that are capable of feeding themselves would have a really hard time adhering to that diet. The diets that we offer through our program are a little bit less stringent, particularly the modified Atkins diet and low glycemic diets. The modified Atkins diet has some similar principles to the ketogenic diet, but is a lot less extreme and definitely more palatable. It does have some carbohydrate restriction to 15 to 20 grams of carbohydrate per day. To put that in perspective, your average granola bar is going to have between 20 and 30 grams of carbs. So it really definitely is still a big change in diet. And it's a ratio of 1 gram of fat to 1 gram of combination between protein and carbohydrate. The big thing that I want to drive home is that there's a lot of information available on the web, on the internet, and these diets, they can have some significant health consequences. So if they are something that you're interested in, you should talk to your physician. It would be important for you to establish with a nutritionist and a dietitian and have your doctor follow urine and blood testing while the diets are underway. And so just to summarize really quickly, about a third of patients with epilepsy are medically refractory. Again, they aren't responding to 2 or more medications prescribed appropriately at adequate doses. And the good news is that there are a lot of surgical and non-surgical options for patients that don't respond completely to seizure medications. Medically refractory cases should be managed at an epilepsy center, preferably by an epilepsy specialist. And it's a really exciting place to work right now because the field is evolving and we're seeing a lot of changes. And so I think over the next even 5 to 10 years, I'm hopeful that we'll have not only some new pharmacologic options, but some newer devices and perhaps some newer surgical strategies to offer patients. And that's all I got for you. I don't know if I didn't leave that much time. I have 1 minute for questions. Right over here.
I don't know if I need a mic or if everyone can hear me. But I've got to say the main question I have, and thank you for all that information, Dr. Toub. I know I worked with you just recently here in the sleep center since I am an epilepsy patient here at Providence. And I'm just curious as to where the talk is about just some basic herbs, because I know that probably you heard me mention
Well, I think you kind of shed light on a broader point, and I think a lot of what you're talking about kind of tumbles over into the lecture on marijuana. There are a lot of things that people anecdotally find that have been helpful for their seizures, but unfortunately, we don't have data to support all therapies. And it's great that you've been able to find something that helps with your seizures, but without having data that tells us, number one, is it effective? Number two, if it's effective, what type of epilepsy is it effective for? Number three, if it's effective, what does it do 10 years down the road? Is it going to cause any significant side effects? Are there any harms? And number four, does it interact with any medications? Can it worsen any other physical illnesses? The therapies that we offer patients are heavily grounded in evidence. And unfortunately, right now, there isn't a whole lot of evidence to support naturopathic remedies. Certainly, you'll hear from some of the speakers later on that marijuana has been a hot topic, and there are some trials that are underway. But until there is some sort of scientific evidence that actually can support using those sorts of alternative therapies, most epilepsy centers will not be offering most of those to patients. It's hard to condone something without being able to adequately talk to patients about what the potential risks and benefits and side effects are. All right. Thank you, everyone. I think it's time to eat.